Good afternoon. The lights are bright, indeed. On behalf of the APA Practice Directorate and the Practice Organization, I want personally to welcome all of you to this, our 28th State Leadership Conference. As Sandy said, we are indebted to all of you for the work that you do on behalf of the profession now and will continue to do. I know that this State Leadership Conference will leave you exhausted, but hopefully invigorated and feeling a little more empowered as leaders to be part of the solution to the healthcare challenges that are facing our nation and certainly facing our profession. My first address to you as Executive Director for Professional Practice was 2 years ago, when members of Congress were in the throes of debate about healthcare reform. And I talked with you then about psychology's unique role in healthcare and our inefficient and fragmented delivery system with its ever-rising cost and variable quality. I discussed the need for expanded access to care for 46 million uninsured Americans and for a more integrated and coordinated delivery system that pays far more attention to prevention and wellness care. As I emphasized in my 2009 keynote, psychologists have a unique role to play in the prevention and management of chronic disease. We are, after all, the experts in behavior change. Our interventions prevent unnecessary disability, help workers keep their jobs, and improve quality of life. Clearly, psychologists have the training, skills, and expertise to play vital leadership roles in a healthcare system that still faces considerable challenges. In keeping with our 2011 conference theme, my speech is entitled, Leadership in an Evolving Healthcare System. More now than ever, you and your colleagues have critical roles to play in serving as leaders for professional psychology. Each of us has a responsibility to help other healthcare professionals understand what we do and understand the contributions that we make to the health and well-being of our citizens and our nation. Quite frankly, we are undervalued by many other healthcare professions that see the healthcare teams of the future composed of physicians, physician assistants, nurses, and other physical medicine providers. If we want to be valued as a healthcare profession and included as partners with other disciplines, we must be visible in the broader healthcare arena and willing to assume necessary leadership positions. If we abdicate leadership roles, we give others the power over our future as healthcare professionals. While leaders demonstrate numerous attributes, let me highlight just a few. Curiosity, competence, dedication to goals, creativity, motivation, and courage. Leaders are dedicated to translating these qualities into action. They take a stand for what they believe in and work to convince others to think and act differently. Driven to finding better ways of doing things, leaders often take paths that others fear to tread. They empower people by providing skills and guidance that enable us to move forward. And they work at building strong relationships with others, inspiring trust and confidence in the process. Leadership is not just about doing a job. It's about making a difference. To serve as effective leaders, we must understand the context for our leadership roles, namely the changing healthcare system, and particularly the impact of the Patient Protection and Affordable Care Act that President Obama signed last March. The Affordable Care Act resulted from months of intense congressional action and serves as a reminder that fundamental legislative changes do not happen overnight. Congressional tinkering over the 75 years since President Roosevelt attempted to enact national health insurance has yielded very little by way of major change in our health programs, except for the addition of Medicare and Medicaid by President Lyndon Johnson and the addition of Medicare prescription drug coverage by President George W. Bush. The new health care reform law is more than just a big change. It promises to be transformative. The old framework that many of us have known is disappearing. We don't really know what the new normal is going to look like, and that creates a lot of uncertainty and angst among consumers and healthcare providers in all fields, not just in psychology. The Affordable Care Act, which preserves our system of private employer-based health coverage, embodies many changes that experts believe will positively impact patient care. It provides for significant innovation with a focus on improved patient outcomes achieved through integrated care systems. It provides for fundamental payment reform, including capitation and bundled payments, expansion of pay for performance, where payment will be linked to outcomes in patient care, refocusing the system on wellness and prevention, and levels of transparency and accountability never before demanded of our system or of its providers. The Affordable Care Act provides for expanded coverage to include 32 million additional Americans and a number of insurance market reforms. Importantly, the federal law also incorporated the Wellstone-Domenici mental health parity provisions, mandating that mental health services must be included as basic services even in Medicaid programs. Mental health services are no longer optional and must be provided at parity with physical health services. And the Affordable Care Act provides for health insurance coverage for more U.S. citizens through expanding Medicaid eligibility, developing the health insurance exchanges at the state level, requiring individuals to have insurance coverage, and imposing fines on employers who do not offer coverage. The Department of Health and Human Services is the principal federal agency in charge of implementing the Affordable Care Act, and Secretary Sebelius is committed to transforming health care in this country by increasing insurance coverage and making that coverage more affordable, by reducing health care costs while promoting high-value, effective care, by emphasizing primary care, prevention, and wellness, by improving health care quality and patient safety, ensuring access to culturally competent care for vulnerable populations, and promoting coordinated evidence-based care for individuals with behavioral health issues. The department has initiatives focusing on the promotion of early childhood health and development, helping Americans achieve and maintain a healthy weight, preventing and reducing tobacco use, and accelerating the process of scientific discovery to improve patient care. Psychologists can make substantial contributions in all of these areas. The experts believe that without an integrated care system and a revamped payment system, that we have no hope whatsoever of slowing the cost trajectory or accommodating any increase in services for 32 million more uninsured Americans. With the new health care reform law, there is a focus on both public and private sector delivery system innovation through such programs as medical homes and coordination of care. Payment reform will emphasize a transition from fee-for-service to global fees and salary-based payments aimed at slowing growth. Accountable care organizations, or ACOs as they are called, are strongly encouraged under this new health care reform law as the model for developing delivery systems. The Centers for Medicare and Medicaid Services defines an ACO as an organization of healthcare providers that agrees to be accountable for the quality, cost, and overall care of Medicare beneficiaries who are enrolled. So while it's unclear exactly how these ACOs will be structured, large integrated systems that directly employ physicians and other providers will likely be the first to evolve into ACOs. These systems, including multi-specialty groups and hospital systems, care for large numbers of individuals and account for a sizable portion of our healthcare expenditures. About 5,800 hospitals account for about 30% of all of the healthcare outlays in the United States. And because of their size and capacity for integrated service delivery, they will play a huge role in setting standards and driving practice trends for all of us. For example, increasingly these systems are purchasing solo and small group medical practices. Many large systems of care have made huge strides in health information technology infrastructure, and they will lead the field in producing and using evidence in clinical decision-making. Despite the promise of these systems, however, very few now exist. Most parts of the country have no such integrated care systems, and only an estimated 15% of physicians are currently affiliated with them. The implementation of ACOs face major challenges because most physician practices are solo or small group independent practices, and because fee-for-service remains the dominant payment model. In addition, the ACO model may be difficult to apply to solo or small group practices due to a lack of capital to invest in electronic health record-keeping systems. The quality improvement training needed for staff by ACOs poses another obstacle. Simply put, ACO demands resources that solo and small group practices just do not have. The patient-centered medical home, which many of you have heard about, is another model of service delivery being tested as a result of the Affordable Care Act. The model is similar to ACOs, focusing on comprehensive, integrated, team-based care, although patient-centered medical homes generally are envisioned as functioning on a smaller scale than ACOs. That means they might be more accessible to psychologists currently in solo and small group practices. The concept of patient-centered medical homes makes intuitive sense. But what we don't know is what populations the model will best serve and whether or not that model really will result in cost savings. This month's current issue of Health Affairs reports on the first national demonstration project of patient-centered medical homes. 36 mainly small, independent family practices were selected for transformation into these patient-centered medical homes. According to the demonstration project report, even with expert consultation and other outside assistance, 2 years was insufficient to implement the paradigm shift embodied in patient-centered medical homes. The attempted implementation of teams of care requiring new roles for healthcare professionals proved to be a major challenge. So did the poor interoperability of current health information technology. Clearly, electronic health record-keeping systems must be more reliable, less expensive, and more user-friendly than the systems now in place. Despite the limitations of our current delivery system, leaders in the private sector see opportunities for innovation and change as well. Health Affairs editor Susan Dentzer, our SLC keynote speaker in 2009, interviewed Glenn Steele, the CEO of Geisinger Health Systems in Pennsylvania last June. Steele suggested that we need to move to a payment reform model where insurance companies do better only when the health status of the insureds improves, rather than perpetuating a model where companies make money off of the difference between what they collect in premium dollars and what they pay out in claims. I'll bet he is really popular with the insurance industry. Achieving that outcome will require payers and providers to work together very differently than we have in the past. Steele suggests that we might start looking at high utilization of services by high-cost groups of patients. Payers and providers could then work collaboratively to gain consensus about what the optimal outcomes would be for those patients and ultimately determine what incentives would be appropriate for achieving those outcomes. Further, he argues for a fundamental change in clinical delivery models, noting that we should learn from everything we do so that the system thrives on continuous innovation, just as strong leaders do. Without innovation, Steele believes an unsustainable cost trajectory will ultimately lead to cost controls. And I was in private practice for a long time. I know what those look like, and none of us like them. Aside from Geisinger, there are other large private systems that are leading the way in innovation, including Intermountain Healthcare, Dartmouth-Hitchcock Medical Center, the Mayo Clinic and the Cleveland Clinic, and Denver Health. We would be well advised to engage our psychologist colleagues in these systems to help us educate practitioners about future opportunities in our evolving healthcare system. While the Affordable Care Act offers the potential to positively impact healthcare, we have a lot of work to do as regulations are implemented at the national and particularly at the state level. Implementation of healthcare reform may offer yet another test of our political system as Democrats and Republicans play out their very different healthcare visions. The federal healthcare reform law does not create a new system, but does fill gaps in our existing system. It's a product of both a fragmented political process, which compels compromise, and a fragmented health system, which limits reformers' options to move away from the status quo. Strong leadership, indeed, will be required to realize the potential and promise in healthcare reform. Fixing our broken system will require courageous and innovative leadership on all fronts. There will continue to be strong, reasonable voices all along the political spectrum that disagree about what changes are necessary, how to fix what's broken, and how to pay for it. Among the guiding principles embodied in the Affordable Care Act are that evidence-based care should be delivered by interdisciplinary teams and that patients should be embraced as part of those teams. This new approach will require a huge shift in our current healthcare culture. Our culture values quick and easy fixes over the hard work required for solutions with staying power. A good example is the increasing reliance on medications as a first-line treatment for mental health disorders, even though we know that psychotherapy is at least equally efficacious and, unlike medication, has positive effects that endure beyond treatment. Another required shift in the healthcare culture involves moving from an autonomous practice to team-based care. As experience with the initial national demonstration project of patient-centered medical homes suggests, this transformation will be difficult to achieve. When it comes to making changes resulting from the Affordable Care Act, the states definitely will be in the driver's seat. They are not just participating in healthcare reform, they are and will be leading it. Moreover, states directly regulate the practice of healthcare professions and the healthcare workforce. State-level policies and practices will determine whether healthcare reform results in increased access and more affordable care. Under the Affordable Care Act, states have a particularly important role, particularly regarding currently Medicaid expansion. Each state has substantial flexibility to determine the final form of Medicaid as it will be carried out in its jurisdiction. States are expected to revise their eligibility rules to accommodate another 16 million beneficiaries and reach everyone who lives at or below 133% of poverty. Further, as a result of the Affordable Care Act, states are tasked with creating health insurance exchanges and new rules for how they will operate. Healthcare reform, though, comes at a very difficult time for our states, which are suffering from high rates of unemployment, severely depressed revenues, increased demand for services including Medicaid, and workers stomping around in the streets in Wisconsin. With their budgets in the worst shape since World War II, states anticipate shortfalls of more than $136 billion over the next several years. And as states' budget woes worsen, many newly elected governors seem to favor paring back Medicaid. In fact, several states may bid to drop out of the program altogether. Some have just asked the government to give them vouchers so they can let their poor people buy insurance in the private market. And we know that they will be wanting to move more to managed care to cut costs. Many states see managed care as the most viable route to controlling cost, despite issues we've all had about access to care and the adequacy of provider networks. As our members have all too painfully experienced, the application of managed care cost controls has often resulted in reverting to payment levels that we were seeing decades ago. The Affordable Care Act also puts the onus on states to be innovators in creating new models through medical home grants and other integrated care initiatives. We don't know exactly how these programs will take shape, but SPTA leaders need to be involved to help ensure that these emerging models of care at the state level include behavioral health and psychological services. If we aren't at that table, folks, it will be because we are on the menu. Changing market demands in healthcare mean we need new models for delivering services in a more agile, responsive, and effective way. Some states have empowered psychologists and other health professions to compete more effectively in the healthcare marketplace. For example, Washington State Psychological Association successfully advocated several years ago for a change in state law that enables psychologists to form interprofessional group practices. Such practices are in a much better position than a single discipline practice to contract with health plans to deliver services to populations of patients. The success of healthcare reform will depend upon collaboration among regulators, insurers, and providers. That success hinges on an approach to regulation that's flexible enough, particularly where antitrust issues are concerned, to ensure that these groups can cooperate to pursue the goal of providing access to high-quality care at a cost that the public will accept. So be sure to attend our Monday morning plenary on the future of behavioral health care. You will hear from insurance industry stakeholders and leaders, including a state insurance commissioner, a managed care psychologist CEO, the director of a large public behavioral health care system, and the vice president of a national organization representing the interest of the employer community. This employer community is clearly a major stakeholder in the evolving healthcare system. They're the ones that make the decisions about what kind of healthcare benefits they're going to offer to their employees. Employers want improved quality, safety, and efficiency. They expect evidence-based healthcare achieved through provider contracting, benefit plan design, employee decision support, and public policy advocacy. And as those contracts are set, vendors, including psychologists, will be selected and rewarded for incorporating evidence-based practice. Through benefit design, differential coverage will be used to encourage effective care, with coverage tiers based on strength of evidence. Network selection will be based on performance. Employee cost savings and sharing will be encouraged for them to use high-performing providers. Healthcare providers, hospitals, and networks will be recognized for excellence and receive higher payments. So given this climate, healthcare professional organizations are seeking to better position the providers they represent as valuable contributors to health services delivery. This past fall, the Institute of Medicine and the Robert Wood Johnson Foundation released a visionary report, The Future Not of Psychology, the Future of Nursing, Leading Change, Advancing Health. Nursing is the largest group of healthcare providers in this country, with more than 3 million registered nurses and 140,000 advanced nurse practitioners. The report proclaimed that nurses, quote, should practice to the full extent of their education and training, unquote, and that their, quote, contributions to the healthcare team should be maximized, unquote, through such strategies as updated and standardized scope of practice regulations and implementation of, quote, specific regulatory, policy, and financial changes that give patients the freedom to choose from a range of providers, including advanced nurse practitioners, to best meet their health needs. That's quite a powerful endorsement of the perceived value of nurses to our healthcare system. As psychologists continue to face challenges on numerous fronts, it's obvious that we too will have to transcend traditional roles and practices, begin to embrace new skills, and occupy somewhat foreign positions in order to ensure the future growth and success of our discipline. As important as we think we are to healthcare, and as much as we value the skills we bring to alleviating pain and suffering, psychologists are small in number compared to other healthcare practitioners. According to the U.S. Bureau of Labor Statistics, our healthcare system includes around 600,000 physicians, those 3 million nurses again, and 200,000 pharmacists. And in the mental and behavioral health realm that we have primarily occupied, there are 30,000 psychiatrists, 347,000 licensed clinical social workers, 4,200 psychiatric advanced nurse practitioners, 55,000 licensed marriage and family therapists, and more than 120,000 licensed professional counselors. Anybody add all those up? We have about 108,000 licensed psychologists. So even when we confine it to the behavioral health care workforce, we are only 16% of that work group. That means that the chances of any one patient in our healthcare system ever meeting a psychologist are very small indeed. So to ensure that psychological perspectives inform healthcare more widely, we've got to work differently in an interdisciplinary fashion and as leaders, team members, and consultants. Employment for psychologists is expected to grow 12% between 2008 and 2018, about as fast on average for all occupations. With job prospects, and I hope the students are listening, the best in prospects in healthcare, the best for those with a doctoral degree from a leading university in an applied specialty such as health or counseling. Psychologists with additional skills in quantitative research methods, program design and evaluation, and information technology will probably have a competitive edge over psychologists that don't have those skills. The demand for clinical psychologists also will be fueled by rising healthcare costs and greater incidence of chronic illness associated with unhealthy lifestyles that involve smoking, alcoholism, drug addiction, and obesity. Currently, about 75% of all of our healthcare dollars in the United States are spent on treating chronic illness, which continues to increase among individuals in midlife and early old age. The growth in chronic illness makes both treatment and prevention more critical than ever before. Individuals with chronic conditions require ongoing attention to manage symptoms and prevent complications and comorbidities. As I mentioned early in the speech, psychologists are well suited to help meet the growing health and mental health needs related to chronic illness. The rising elderly population will increase the demand for psychologists trained in geropsychology. Further, the need for psychologists to work with veterans and their families will continue. And the growing number of employee assistance programs should lead to other employment opportunities for clinical and counseling specialties. Industrial, organizational, and applied psychology has potentially the highest growth rate, about 26%, and they will be in demand to help boost worker productivity and retention rates in a wide range of businesses. IO psychologists will help companies deal with issues such as workplace diversity and anti-discrimination policy. Companies will also use psychologist expertise in survey design, analysis, research, developing research tools for marketing evaluation and statistical analysis. But these new opportunities and emerging systems of care call for a new kind of leadership. Specifically in regard to healthcare, there's several key concepts that we must understand and accept, that's the operative word, and encourage our colleagues to embrace if we're going to provide the leadership our discipline needs from us. So if you don't remember anything else I say this afternoon, you need to remember the following 3 mantras to sort of guide us along the road ahead. Number 1, performance matters. We all work hard, but what really counts are the patient outcomes that result from our treatment. Many of our colleagues view with skepticism the use of performance measures by insurance and managed care companies. The measures are often seen as instruments used to limit care or restrict care or, God forbid, evaluate our clinical competency. We're very quick to challenge performance data and the methodological problems associated with them. But we are also a discipline that highly values data, and we are intrigued and mesmerized by it. So perhaps we need to be part of the solution here and work to ensure that the performance data is psychometrically sound and that it is used for the right purposes. We do good and important work, but we'll have to work differently in the future if we want to be valued as team members in the healthcare system. Delivering even better care with improved outcomes for our patients is in everybody's best interest. Solid, well-developed, psychometrically sound performance measures not only help us provide better care, as the data is showing us, they also, if made public, may help you grow your practice. Here's the second key concept. Value is not a bad word. We make purchasing decisions every day, and we expect value in the products we buy, even something as simple as a set of tires for our car. Should our patients expect anything less from us? In some markets, insurers are already incorporating cost and quality indicators in insurance product design so that patients will have to pay more or might not be covered at all if they want to see physicians or other providers who are more expensive, less efficient, or in lower quality practices. And my third point, improving performance requires teamwork. As an individual clinician, I know I have limited impact on my patients' outcomes. Coordination, information sharing, and teamwork across providers and disciplines, including the patient and his or her family network, are necessary for improved outcome and improved patient value. However, teamwork doesn't come very easily to a lot of us, because after all, we've been trained for independent practice, right? And we believe that autonomy is critical for providing quality care. Many of us have not been trained to work as part of an interdisciplinary team. And we need to humble ourselves a little bit and understand that we're more likely to thrive in integrated practices that embrace teamwork and that will help us provide better patient care. So the 3 takeaway points: performance matters, value is not a bad word, and improving performance requires teamwork. This shift to value-oriented, performance-driven, team-based healthcare will require us to adapt or even change some of our ways of working that are embedded in our education and training systems. Change is and will be difficult, particularly for those of us who have been in practice for a while. And these changes will have a significant impact on how we train and need to train our next generation of psychologists, at least those that are going to be in healthcare. Training needs to adapt its focus and emphasize evidence-based practices, lifelong learning, and interdisciplinary team-based care. The big healthcare system redesign changes are going to take some time, so some of us have a little reprieve here for a while. I don't believe that independent practice, even in the healthcare arena, or the fee-for-service payment system is going to disappear completely in the near future, because 89% of all physicians continue to work in solo practice or small group practices of 10 or fewer physicians. And about 51% of our APA practice members are in full-time independent practice, although we're seeing that percentage drop. Defending the status quo is no longer a viable strategy if we are to remain a viable healthcare discipline. The push for increased value and better patient outcomes will continue to be emphasized and rewarded by the employer and payer communities. For psychology, moving beyond the status quo often means really moving outside of our comfort zone. It means reevaluating our professional roles, whether in private practice or institutional practice, and envisioning innovative ways of assuming leadership roles and shaping the future for our profession. In shaping that future, we must continue to nourish and cultivate the strong partnership between the APA Practice Organization and the SBTAs represented at the State Leadership Conference. As I mentioned in my SLC speech last year, when we collaborate, when we tap into an energy that we can't generate on our own, and we can achieve results that can't be accomplished when we work alone. A steady pipeline of well-prepared leaders who are skilled at impacting public policy and public opinion will help us in our leadership mission. Our visibility, our credibility, and our value among health and mental health professions, as well as the public, are all at stake. We don't need to take anything for granted. We believe that this State Leadership Conference will help prepare you to further serve as the leaders who I am sure will help pave the way to a brighter future for professional psychology. Thank you. Thank you. And now I want to take a moment of personal privilege to recognize several special psychologists among us this afternoon. First, as I said, I'd like to thank all of you for the many ways in which you support the profession by serving as leaders in your SPTAs and other organizations that reflect psychology's mission, by participating in APA governance and APA practice organization governance groups, through your political giving and other contributions to our state advocacy initiatives, just to name a few. But some of you have been particularly generous in your financial support of the APA practice organization through your contributions to our Practice Leadership Circle, our annual major donor fund. 56 of our colleagues joined this prestigious group in 2010. Their names and generous donations are presented on the slide behind me. 13 of them are here with us today. So I would like for the following members of the 2010 Practice Leadership Circle, when I call your name, to stand. And please, for the sake of our timing, we don't want to make Dr. Abrahamson nervous about getting off schedule, hold your applause until I complete the list. I'd like to start with our own Dr. Norman Anderson from Washington, D.C. Hold your applause, please. Dr. Barry Anton from Washington State. Where's Barry? Stand up. Dr. Paul Burney from Texas. way back there. Dr. Melba Vasquez, also from Texas. Dr. Jean Carter from Washington, D.C. Dr. Suzanne Bennett Johnson from Florida. Dr. Roz Dorland from New Jersey. Dr. Carol Goodhart from New Jersey. And Dr. Matthias Hagofsky, a third New Jerseyite. New Jersey holds the prize this year. Dr. Seymour Gross from Minnesota, excuse me. Dr. Tricia Stark, also from Minnesota. She'll be arriving later this evening. Dr. David Hill from Kansas. Dr. Karen Postal from Massachusetts. And last but not least, Dr. Sheila Schuster from Kentucky. Please join me in giving these colleagues a hearty round of applause.